Thank you to the chairs and the scientific committee to allow me to speak in this wonderful meeting again. I'm going to try and clarify a little bit the single agent gemcitabine versus doublet versus Folfirinox question. I have a lot of disclosures. So first off, the question of gemcitabine versus 5-FU, as you saw earlier, might not be completely answered, but we're not going to go through it too much today. Just to say that the positives for gemcitabine is that in terms of the first trial was that it met its primary endpoint of clinical benefit response, but had a small but statistically significant overall survival and a larger proportion surviving 1 year. We're critical of things that we like to critique and maybe not critical all the time. And we weren't overly critical of this first gemcitabine versus 5-FU, the Burris trial, because it was small. 126 patients is not a very large trial. It was company-sponsored, which you can argue might not make a difference, but it also can. It should have been repeated. And most importantly, it actually gave 5-FU in a suboptimal way. When 5-FU is given in a more optimal way, as was demonstrated in an abstract presented earlier, maybe the differences might not be so much. This is just an example of 5-FU versus gemcitabine, not in the metastatic setting, but in the adjuvant setting from SPAC3, in which an optimal 5-FU was given versus gemcitabine, and the differences didn't exist. However, again, it's a different setting, not metastatic disease, but in resected patients. So this is a slide that I produced all my life now with gemcitabine versus gemcitabine plus your drug here, which was the standard of therapy to try and find basically a couplet that would beat gemcitabine, to answer the question of gemcitabine versus couplets. And for over 2 decades, we really didn't have a second drug except for the erlotinib, which once again is also in question, especially after the last presentation, although again done in a different setting than metastatic disease. This is a list of your drug here. The white, I was generous with the ones that are in white are things that may have had suggestions in phase 2 trial, though most of them really didn't, that they deserve to go on to phase 3. The yellow was just pitiful. And blue, they didn't even bother with a phase 1. The same was actually, they didn't even bother with a phase 1. Erlotinib at least did a phase 1 part way. And red was the horrible situation where the phase 2s were actually negative and suggested not to go on, but it was done anyhow. And to be fair, I included my own as the first one. In that case, my phase 2 trial was negative, but the phase 2 trial conducted with the same regimen by Giscard actually turned out to be positive, which is why we went on. However, I did have a negative phase 2, which might suggest not to go to phase 3. This, as you've all seen, is the one quasi-positive phase 2 trial phase 3 trial for a long time with erlotinib plus gemcitabine versus gemcitabine plus placebo. It reached statistical significance, but everybody questioned clinical significance, which to us is more important. And it was not well taken up by most places, and in fact, it was a Canadian-led trial, and the drug was not approved in Canada. We have tried to improve on gemcitabine. We wanted to believe we could improve on gemcitabine for a long time, so we actually convinced ourselves that we could. And we have 2 meta-analyses, or 2 combined analyses that were performed early on, and there was data that came out after these 2 analyses, in which both of them showed a hazard ratio of 0.91 or 0.85, neither one of which is as good as the 0.81 we got with gemcitabine or erlotinib, yet we concluded that gemcitabine couplets might be useful in this disease. I will say that there may be special situations like the BRCA2, Fanconi, or PALB2 mutated patients who may benefit from platinum-based therapies. And so the book is not closed on platinum in particular in this disease, but I'm dealing with the general population in this discussion. And again, gemcitabine versus couplets with negative phase 3, there have been a lot of them. There are some that may have biomarkers. Masitinib most recently, erlotinib needs one, although I'm not sure it will get one based on the data we're seeing. And in fact, the RTOG 0848 adjuvant trial is going to drop the erlotinib arm from their trial, the one conducted in the United States, and now in the EORTC as well. Capecitabine and 5-FU, except for infusional 5-FU, these studies were borderline, suggesting maybe there might be some slight benefit to adding either 5-FU or capecitabine to gemcitabine. And the better performance status patients may have derived benefit, but they didn't reach the statistical significance in their trials, and therefore are negative trials, regardless of how we might recombine them or dance around the truth. They're negative. Cisplatin and oxaliplatin, again, like I mentioned, there may be special patients that benefit. The trials were unfortunately negative, although certainly there was a strong signal from the trial presented by Dr. Louvet. So we come along to nab-paclitaxel plus gemcitabine. You've heard a lot about it today, including the presentation of the data I'm about to show you. The preclinical models, which were done after the initial trial started, suggested there was benefit for combining nab-paclitaxel with gemcitabine. How it synergizes is still under debate in the preclinical setting, as not all the laboratory data has been consistent. However, in 67 highly selected patients in a phase 1-2 trial, again, highly selected patients, the overall response rate was spectacular and the overall survival was very good. It suggested going on to a phase 3 trial because these results were spectacular. And appropriately, the phase 3 trial, as you've seen earlier, was presented by Dr. Tabernero today and was presented by Dr. Von Hoff at ASCO. You've seen the schema, planned 842 patients. And these are the overall survival data. You can see a separation of the curve that encourages us a little bit more than the gemcitabine and erlotinib trial, where the curves were still very close together, although they were always just a little apart. The hazard ratio here is 0.72, and we're supposed to be looking at hazard ratio now, which compares a curve to a curve rather than an individual time point, such as the median or the 1-year survival, when we're looking at the data. And the hazard ratio of 0.72 is considered a significant hazard ratio. And again, here's the data in bigger tabular form with the overall survival, progression-free survival, 12-month survival, and response rate. I will note the response rate here is the response rate by central review. The response rate of 29% was seen when done by investigator review. I think that's an important issue when I get to the next portion of this talk. For safety data, there was more toxicity with nab-paclitaxel, not a surprise, and there is some concern that the patients didn't tolerate this regimen very well, and there's some question if they tolerated better in some portions of the world than in others. Based on the data you saw earlier, there is reason to question that, and it may be partially due to availability of growth factors at various places, which may have helped prevent some of the febrile neutropenia that occurred. But febrile neutropenia was overall infrequent in this trial. So for gemcitabine nab-paclitaxel, this does seem to be a reasonable couplet and better than gemcitabine very clearly. Hazard ratio is 0.72. We don't have clear biomarkers, but has been mentioned several times during the course of the afternoon. SPARC is awaited. And for gemcitabine couplets, it's likely the choice or the regimen of choice, except we still need to investigate a little bit more about these special populations that make up only a small percentage of pancreatic cancer patients, but maybe a very important one. With BRCA2, Fanconi, or PALB2, DNA repair deficient tumors may actually respond better to platinums, and they may benefit better from those and or PARP inhibitors, which are still under investigation. So it brings us to Folfirinox. It's a phase 2-3 randomized study, and I stole these directly from Dr. Connois, so they have a little bit more change. So it's a robust randomized phase 2, gave them a strong signal to go forward. I point this out because I think this is the one trial that best demonstrates how best to do clinical trials in pancreatic cancer. They did a robust randomized phase 2. That has the best supported go forward I've seen in pancreatic cancer therapy. And the results of the randomized phase 2 led to the randomized phase 3. And the randomized phase 3 trial had great results. Our response rate was better, 31.6% total response rate. This is investigator assessment, more similar to the 29% that the nab-paclitaxel showed. They had progression-free survival data that you can really see a separation on. The curves get very separate. And the overall survival, again, you don't have to squint your eyes to see the difference in the locations of the two curves, favoring the Folfirinox arm with a hazard ratio of 0.57, which is quite good, and actually the best we've seen in pancreatic cancer. 11.1-month median survival for purely metastatic patients is also quite spectacular, though there may be some selection overall to the patients because they all had good performance status, and there was a higher proportion of tail of the pancreas patients in this and the nab-paclitaxel trial than we'd ever seen in phase 3 trials in the advanced setting. Safety, once again, favored that there was more toxicity in Folfirinox. Folfirinox had higher febrile neutropenia rate, over 5%, with liberal use of growth factors. And of course, there were other toxicities such as fatigue, neuropathy, and diarrhea that were more significant in the Folfirinox arm than in the gemcitabine arm, with the only toxicity more common in gemcitabine arm being elevation in liver function tests without necessarily any evidence of liver damage. So my conclusions on Folfirinox is clearly the most robust phase 3 results we have in metastatic pancreatic cancer. It is a limited patient subset, and realize that we can't apply it to everybody. It was PS0 or 1 only and limited patients to age less than 76. The trade-off was a side effect profile, so when giving these regimens, you're giving more side effects. And includes a platinum to decrease the question about BRCA2, etc. Largely, it's being used in a modified form around the world. People have modified the doses. Some people modify the doses of all drugs. The most common that we've found is dropping the bolus 5-FU, but it's certainly not the only modification we've seen for Folfirinox. So what about the question of Folfirinox versus nab-paclitaxel? Because I think for the good performance status patients, and I'm not addressing the performance status too, but for the good performance status patients, I think nab-paclitaxel clearly beat gemcitabine. We don't really know the answer of Folfirinox versus gemcitabine and nab-paclitaxel. I'm not pretending that this is an absolute answer. I'm just looking at some of the things we have. So the populations had similarities. The median age, the gender, 100% were stage 4, the site of primary, and the percent with liver involvement were all similar between the two demographics of the trials. Differences in the population exist, though. IMPACT, in fact, had some PS2 patients. It represented less than 10%, but the Karnofsky performance score of 70 is actually equivalent to a performance status of 2, though the good 2s, whereas the PRODIGE did not allow any patients with performance status of 2. IMPACT was worldwide, and we don't know if that truly impacts the effects by being so global and having so many different sites with so many different practices baseline, whereas PRODIGE was more uniform, being conducted in France only. And again, age was greater than 75 was allowed on the IMPACT trial, though they, again, represent a very small fraction of the patients. And the median number of sites, if this is important, was different, in that there were 3 in IMPACT and 2 in PRODIGE. But again, we don't know if this is an important prognostic marker that would have made a difference in the trials. The toxicities were not that different, although both had toxicities. The neuropathy looks to be more in the nab-paclitaxel trial, but it went away faster than it does with oxaliplatin. So tolerability, you really can't compare. There certainly are some interesting more side effects with both regimens than with gemcitabine alone, certainly. Differences in efficacy. Well, the overall survival for Folfirinox, the median, a time point, again, not the hazard ratio, was 11.1 versus 8.7 months. Comparison is limited by the differences in the trial that I've already mentioned. And the control arm in both trials, intriguingly, had the same median survival, 6.8 and 6.7 months. However, the fact is we're supposed to compare curve to curve, the hazard ratios, not medians, not time points, not 1 year survival. And this is more difficult to check unless you've invented PowerPoint, which I'll show you in a moment. The response rate was really similar. Now, I'm about to make several statisticians, if there are any in the room, cringe. This is very difficult to see, or more difficult than I'd like it to be, but I actually superimposed the curve using PowerPoint. It's not legitimate. It's intriguing. One of the things that I note is towards the end of the curves, despite the fact that they're both at 3-month intervals, they kind of start to separate as if there's something wrong with PowerPoint that you can't adjust the curves or adjust the scales to be identical. But regardless of that, the gemcitabine arms track remarkably identically. It has been a remarkably consistent drug throughout our history, having fairly similar survivals on every trial. And you can see that there does appear to be better results for FOLFIRINOX, but again, this is an illegitimate thing that I've done and probably will be punished for it later by some god. But the fact is that we can't tell if one regimen is truly better than another in terms of FOLFIRINOX versus gemcitabine plus nab-paclitaxel. It's just intriguing that there are differences. We won't know the answer unless somebody does a randomization between the two, and I'm not sure that that's ever going to happen. So impact versus prestige, again, comparing across trials is not truly possible. I've shown you that there's significant differences in the trials, the demographics, where they were conducted. The key eligibility of performance status and age differs in the two studies. Despite this, the gemcitabine control arms look remarkably identical in terms of numbers and in terms of when I superimpose the curves illegitimately thanks to Bill Gates. The bottom line, both are options. We don't know if one is truly better. And while survivals appear to favor FOLFIRINOX, there could be differences. And of course, with both regimens, if the toxicity is too much, we're going to be modifying them. And what we don't know is if the modifications we do out front will actually lower the efficacy from what we're seeing on the phase 3 trials. Finally, they're both for performance status 0 or 1, with gem-nab-paclitaxel extending to the 70% Karnofsky performance status patients. With performance status 2, I don't think we've ever proven anything better than gemcitabine, and I'm not sure that there is a more appropriate regimen for that group. So my last 2 slides. Gemcitabine plus nab-paclitaxel appears to be a better regimen for adding more drugs, at least on the surface, but we're not entirely sure that the toxicities are that different. We're using FOLFIRINOX largely in different doses than used on the trial, and it may happen with nab-paclitaxel as well. There will not be a regulatory submission of FOLFIRINOX. We know that. So the result is this, what I consider mindless clinical trial design, where we add everything to gemcitabine plus nab-paclitaxel versus gemcitabine plus nab-paclitaxel plus your drug here, which is why I appreciated Dr. Tabernero's answer earlier this afternoon when asked which drug regimen to combine new drugs with. He said, base it on the scientific data, which is exactly what we should do in the future. So I thank you very much for the opportunity to speak, and I suspect I'll be getting off without questions.